This is Michael Altos recording part 2 of Transfusion Medicine from Bearish Chapter 16. Now we're going to talk about platelets. Platelets can be collected in a couple different ways. Nowadays, they're mostly collected by apheresis. So a single donor donates platelets and all the other cells are returned back to the donor. But previously, platelets were collected by pooling platelet fractions from a number of different donors. And this is the origin of the terminology a 5-pack or a 6-pack of platelets. That was simply a pack of platelets pooled from 5 or 6 different donors. As I said, most of our platelets now are collected by apheresis, which is equivalent to about 6 to 8 individual donors. And a lot of people will just say a unit of platelets. This is beneficial because it reduces your exposure to multiple donors, and one apheresis unit usually increases platelet count by about 30 to 60 times 10 to the 9 per liter. Platelets can be stored at 22 degrees Celsius for up to 5 days, and there is risk of bacterial contamination when platelets are stored at this temperature. Platelets should be compatible with the ABO and RH typing, but this is not actually required. However, we find that platelets survive better in the circulation when they are compatible, and there seems to be less incidence of hemolysis of the recipient's red blood cells, probably due to some residual plasma in the platelets. Platelets should be administered through a 170 micron filter, not a micropore filter, or the platelets will be caught in the filter. Platelets should be transfused at a threshold of 100 times 10 to the 9 only in patients who have active bleeding in a closed cavity, for example, neurologic bleeding. Usually we try to keep platelets above 75 during massive hemorrhage and above 50 during patients who are experiencing DIC or ongoing bleeding during minor procedures like lines or spinals or other procedures. When patients are not bleeding, they can reliably go about their business all the way down to a platelet count of 5 or 10 times 10 to the 9 per liter. All of this discussion needs to take into account normal platelet function. If platelet function is compromised, then these thresholds may not be accurate. This is all we're going to say about platelets for now, and next we're going to move on to plasma. As we said before, plasma can be described as FFP, which is frozen within 6 to 8 hours of collection, or FP24, frozen within 24 hours of collection. And the goal of freezing them as soon as possible is to preserve the factors 8 and 5, which rapidly degrade. FFP can then be thawed at 30 to 37 degrees centigrade and should be then used within 24 hours. If it isn't used within 24 hours, it's relabeled as TP, thawed plasma, and can then be stored at refrigerated temperature for another 4 days. Having thawed plasma allows for a more immediate availability of plasma because it doesn't need to be thawed, and it allows us to preserve plasma that wasn't used for another 4 days instead of discarding it after 24 hours. We do find reduced levels of factors 5 and 8, and so aside from factor 5 and 8 deficiencies, FFP is really a good way to replace anything that's found in plasma. The other exception is patients who are in DIC and in neonates. We said before that red blood cells need to be ABO compatible. Plasma also needs to be ABO compatible, although it does not need to be RH compatible. However, red blood cell compatibility involved worrying about the recipient's antibodies acting against the antigens on the donor's red blood cells. In the case of donating plasma, we're worried about the donor's plasma acting against the antigens on the recipient's red blood cells. And so the compatibility is really opposite of red blood cell compatibility. So for example, we said patients with type O blood have no antigens on their red cells, and they carry the anti-A and the anti-B antibody. And so we said that therefore, because they carry these antibodies, the only red cells they can receive are type O red blood cells. However, we aren't worried about plasma from a donor attacking antigens on their red cells because they don't have any. And so they can actually accept plasma from any of the blood types. And so while type O blood may be the universal red blood cell donor, type O blood is the universal plasma recipient. And the same holds true for all of the different blood types. Type AB blood, which has A and B antigens on its cells, can only accept plasma from a donor who has no A or has neither A nor B antibodies. And who is that? Other patients with AB blood. And so when we put these together, we see why donating whole blood has a problem. Because you can only accept whole blood from someone who has the same blood type as you, in order that you get red cells and plasma that are compatible with your red cells and your plasma. Plasma is not typically cross-matched. Plasma should be given to patients who are clinically bleeding and have a PT or a PTT which is more than 1.5 times normal. It's also given in anticipation of a major invasive procedure when patients have these lab abnormalities, even if they're not clinically bleeding at the moment. We can use plasma to correct factor deficiencies, especially when there isn't a specific factor concentrate available. Patients who have liver dysfunction with signs of bleeding may get plasma. Patients who have DIC with signs of bleeding, microvascular bleeding associated with massive transfusion, especially once EBL has exceeded 1 blood volume. Plasma can be used to reverse vitamin K antagonists, although we saw in the previous lecture that prothrombin complex concentrates are more effective. Patients who have developed heparin resistance due to an antithrombin 3 deficiency may need an infusion of FFP in order to replete their antithrombin 3 so that heparin has a substrate that it can work upon. Various thrombotic microangiopathies like TTP or HELP or hemolytic uremic syndrome may respond to plasma. And it's often used in the treatment of hereditary angioedema, which is a discussion for another lecture. This is especially useful when the C1 esterase inhibitor is not available. Patients can actually mount an effective coagulation response at only 30% of normal factor levels. Once patients no longer can make effective coagulation, the textbooks say that you should administer FFP at a dose of 10 to 15 milliliters per kilogram, which, as you can imagine, is a very large volume of FFP and may actually be contraindicated in neonates or in patients with congestive heart disease or renal failure or other conditions. The old teaching was that FFP should only be given when it was indicated by lab studies, but the new teaching takes into account formula-driven resuscitation protocols, because we don't want to fall behind due to dilutional coagulopathy. So as patients get more and more crystalloid and colloid and multiple packs of red blood cells, their coagulation factors become further and further diluted out. And so instead of falling behind, various protocols have been developed. Most people are familiar with the 1:1:1 ratio of red cells to FFP to platelets, which has been developed by the military, and there are other protocols that are being used as well. This leads us to an important point about survivor bias. This is a point I actually see in boards questions frequently, and so it's important for us to spend just a moment discussing it. In general, the idea of survivor bias says that a study may appear to show a treatment is more effective than it really is, because people who received it did better than people who didn't receive it. But in fact, the people who died just died before they had a chance to get the treatment. In practical terms, we've seen better outcomes associated with a more balanced ratio of packed red cells to FFP. But we all know that the first thing that comes to the OR is red cells, and then FFP second. So it might be that those patients who are going to die within 10 minutes anyway are the ones who never got around to receiving any FFP. and the FFP may have made no difference at all, whereas the patients who were a little bit more stable lived long enough to get some FFP. And so as a result, we have a survivor bias, where those who were going to survive longer anyway received FFP as a result of their prolonged survival. This is why we want to use massive transfusion protocol packs, so that all products are available from the outset, and we don't have any survivor bias creeping into our analysis of formula-driven resuscitation protocols. One subcomponent of FFP is cryoprecipitate. When FFP is thawed slowly at 4 degrees, a precipitate forms, and that is called cryoprecipitate, and it contains factors 8, 13, von Willebrand's factor, and fibrinogen. I would suggest you memorize it. Not only will it make you look good in front of your attendings, but this is the kind of information that you could definitely see on a boards exam. Cryoprecipitate is used when patients need fibrinogen, for example in DIC or in massive transfusion. It does not need to be ABO compatible, and technically viruses can be transmitted through the administration of cryoprecipitate. Cryoprecipitate is indicated for patients with hemophilia A, who have a factor 8 deficiency, as well as patients with von Willebrand's disease, and this would be appropriate when the specific concentrates are unavailable. As we said before, patients with DIC or other fibrinogen problems should get cryoprecipitate, especially when fibrinogen levels drop below 80 to 100 milligrams per deciliter. Some studies of massive bleeding actually suggest a need for fibrinogen to be above 150 milligrams per deciliter. And we spoke about this in the last lecture, where fibrinogen naturally goes up during the stress state. So a normal fibrinogen is actually low during a trauma or a surgery. Patients who are uremic and not responding to DDAVP can get cryoprecipitate. Those patients who have a factor 13 deficiency. And it's important to remember, some people think that cryoprecipitate is just a concentrated FFP, but it isn't, as you saw in the previous slide, and therefore it would certainly not be appropriate for reversal of Coumadin. Some people want to use it in patients who can't get a lot of volume and they think they'll just use cryoprecipitate instead, but that's really not correct. A unit of cryoprecipitate, which usually has about 10 to 20 milliliters of volume, has about 15 milligrams per milliliter of cryoprecipitate in it, and it will fibrinogen in it, and it will increase your fibrinogen by about 5 to 10 milligrams per deciliter. Usually, if you want a rough estimate on how to dose it, we give a unit per every 10 kilograms of body weight, and at UH they usually dispense it in 10 milliliter units. There is a specific calculation for cryoprecipitate that looks at the exact number of units of fibrinogen you need, and it looks at the difference between the desired and the current fibrinogen, and takes into account your estimate of the patient's plasma volume, as well as the amount of cryoprecipitate in a bag. We will pause here for a moment for you to consider any questions you may have, and then we'll move on with the recording. I'm going to jump ahead in the notes a little bit and talk for a few moments about various strategies that exist in order to prevent patients from needing a transfusion in the first place. And the first is preoperative autologous donation. This is usually done in the days or even weeks prior to surgery, and we've seen this done for orthopedic, cardiac, and prostate surgeries. We don't really see it done at UH hardly at all, but it's still done in many institutions. The idea is that you collect about 450 milliliters of blood from the patient every week, and this can be done weekly until 3 days before surgery, as long as the donor's hemoglobin level is greater than 11, and the units can be banked or even frozen if necessary. And this does reduce exposure to allogenic blood, that is blood from other donors, and this would especially be useful in patients who are known to be alloimmunized, that they have some sort of rare antibody, and it's hard to find safe blood for them to receive. Now this is expensive. It doesn't cut down on the risk of clerical error, which we know is one of the biggest risks in receiving a blood transfusion. And all of the bad things that happen to stored blood will happen to the own patient's blood when it's stored as well. Now, a lot of our patients don't have a hemoglobin of 11 to begin with, so they wouldn't be candidates for this. And often our patients aren't identified far enough in advance that we can take advantage of this program. If we do identify them in advance, we can give epigen injections, which helps, but it is expensive and requires multiple injections. B12 and folate supplements can also help the patient generate more red blood cells. This process is contraindicated in patients who are less than 10 years old, patients who have an infection or who are bacteremic, patients who have aortic stenosis because we don't want to make them hypovolemic, any patient who's had a recent MI or CVA, has congenital heart disease, or uncontrolled hypertension. Another technique that has been used for a long time in many hospitals is ANH, Acute Normovolemic Hemodilution. The way this is done is in the operating room, often after induction of anesthesia, blood is withdrawn from the patient into a specified receptacle, a bag or a container provided by the blood bank, and you continue to withdraw blood until their hematocrit is between 25 and 30, and you replace their blood with fluid in order to maintain euvolemia. The blood is actually stored at room temperature in the operating room for up to 6 hours, and now when the patient has intraoperative bleeding, they're bleeding low hematocrit blood. And then when you transfuse the blood back to them later, it's whole blood, so it still contains the plasma and the FFP. It contains the plasma and the platelets. Now there is a modest benefit shown here. You could maybe reduce their allogenic transfusion by 1 to 2 units, which is good for some surgeries, but not for a very, very bloody surgery. Again, this would be useful for patients who have been alloimmunized, or patients who won't accept blood from the allogenic sources. And it's contraindicated really just as before in patients who are anemic already, patients who have uncontrolled hypertension, or who cannot tolerate a decrease in their volume status, or who need all the oxygen delivering capacity they can manage right up front. Perioperative blood salvage, also known as cell saver. The idea here is that suctioned blood is collected into a reservoir. It's mixed together with heparin or citrate in order to keep it from clotting. The blood is then filtered, centrifuged, and washed. So this for sure causes a dilutional coagulopathy because all clotting factors are removed. All that's left is red blood cells, and the hematocrit of that blood, once it's spun down, can be anywhere between 50 and 80%. Historically, cell saver was contraindicated in patients who had infection, malignancy, perforation of the bowel, and in pretty much all OB cases because of the risk of amniotic fluid. The concerns were that any of these fat or microaggregates or air, other substances, could get into the unit of blood and be transfused back into the patient. Now, modern systems remove pretty much all of the above except maybe bacteria, and we have filters that can remove bacterial cells. The question remains whether these historic contraindications are outdated, and this debate continues. There is definitely data and guidelines that support using the cell saver in patients who have malignancy, especially if the blood is filtered, and even better if they have a chance to irradiate it. We do avoid it completely if there's an overwhelming concentration of cancer cells in the shed blood, and so judgment has to be used whether this is appropriate or not. But the contraindications are not nearly as clear as they historically were thought to be. When is cell saver beneficial? Well, benefit has been shown in major surgeries like cardiac, orthopedic, spine surgeries, patients who can't receive allogenic blood. And a subset of cell saver is post-operative blood salvage. There are many hospitals where chest tube or drain outputs can be either re-infused straight into the patient without washing at all, or collect it into a system that processes the blood and prepares it for reinfusion into the patient. And this, of course, raises questions of coagulopathies and inflammatory mediators that may be in the drain output. Finally, the silver bullet of transfusion medicine would be a hemoglobin-based oxygen-carrying solution, that is, artificial blood. And despite decades and decades of ongoing research, there is nothing clinically available right now. There are some products being studied under clinical trials, and the most common problem with these has been cause of renal failure or the presence of free hemoglobin, which is very toxic to the system. It interferes with assays, it causes vasoconstriction and damage to organs. We do encounter patients who will refuse to accept blood transfusions. There are patients who have religious beliefs that transfusion will lead them to be excommunicated. There are patients who have other religious or non-religious beliefs, and as a result, they would rather die than accept the transfusion of blood products. When we talk to these patients, obviously there's a medical legal issue that we need to clarify the decision-making, the patient's wishes, and their understanding of the risks, benefits, and alternatives. We also need to make sure to speak with these patients about all of the options that exist in the perioperative setting. So these include all blood components, red cells, plasma, platelets, factor concentrates, albumin. How do the patients feel about being on bypass circuits like ECMO or cardiopulmonary bypass? Would they accept blood that has been taken out of the system in an acute normovolemic hemodilution setting? And how about cell salvage? We will stop the recording at this point and pick up with the next video.